So the patient did fairly well on cetuximab maintenance, and in fact continued on it until August 2016. The patient started to complain of more symptoms: weight loss, fatigue, nausea, and then a CT scan of the chest, abdomen, and pelvis done at the time showed progressive disease both in the lungs, and now there were some new spots in the liver. So the question is, what do you do? So there are two options, frankly. Here, there's the option of reinstituting the FOLFIRI or switching to Capox bevacizumab. The decision was to proceed with Capox bevacizumab. That came through a discussion with a physician. At that time, her blood pressure seemed to be well controlled and continued to be well controlled to Capox bevacizumab. And after 2 months, the patient had stable disease. After 4 months, the same, and so continued with Capox bevacizumab through 4 months. At 4 months, the decision was to drop the oxaliplatin and continue with capecitabine and bevacizumab. So this patient progressed on FOLFIRI plus cetuximab. The first question that comes to mind: do you reinstate FOLFIRI? Because technically, it's taken many months before she actually progressed, and so she could still be sensitive to FOLFIRI. So that's one option. The other option, I think it's a very logical option, is to switch both the chemotherapy backbone and the biologic. My own preference would probably be to reinstitute FOLFIRI first and continue with cetuximab, and then if after a scan the progression on FOLFIRI cetuximab, then I would go to Capox bevacizumab. But as I said, both options are very reasonable. So Capox or FOLFOX would be the next option after failure of FOLFIRI, and then the switch of the biologic as well. The most important question is, given the past medical history of this patient, is should we give bevacizumab? We know bevacizumab increases the risk of arteriothrombolic events like strokes, heart attacks, even increase the risk of uncontrolled hypertension. Well, this patient has controlled hypertension, and it's been controlled on just one drug and for quite a while. She also had coronary artery disease that had angioplasty 4 to 5 years prior to the decision to institute bevacizumab or not. And typically 6 to 12 months is a comfort zone. And since for that patient had years of symptom-free coronary artery disease, seems to be well controlled, I think it would make sense to place her on an anti-VEGF agent, specifically bevacizumab. Now, of course, we have 3 agents available on the market: ramucirumab, zivaflibercept, and bevacizumab. And all 3 agents seem to induce a very similar benefit when given in the second-line setting. There doesn't seem to be one that stands out versus the other, except one is more expensive, ramucirumab. Zivaflibercept seems to be a little bit more toxic. And in fact, for most patients, we're very used to bevacizumab, and that would end up being the default. If you look at the NCCN guidelines, all 3 are listed. However, bevacizumab is preferred for that specific reason, that it doesn't make sense to have 3 of the same, but maybe more expensive, more toxic, and we're less familiar with. So for that purpose, would go with bevacizumab. Now, a question that always comes about: okay, this is a patient who has isolated disease both in the lung and the liver. Well, that's isolated to the lung and isolated to the liver, but that's pretty actually extensive because of 2 organs being involved. Nonetheless, there's always this, and should always be a discussion: could we address the local disease first? And the answer, in the patient that has essentially such extensive metastatic disease, localized approaches do not make sense. And thus, this patient at this point would not be eligible for any localized approaches, just systemic approaches with chemotherapy plus bevacizumab.